So let's learn about lichen planus. First of all, we will be saying about the derivation of this word lichen planus. A lichen which means tree moss and a planus which means flat. So this is actually an autoimmune disorder. It is an inflammatory disease of the skin, mucosa and hair follicles. So you can get lesions on the skin, on the mucosa, and you can get lesions even on hair follicles. Now, when you look at these lesions in lichen planus, they are usually remembered as 5 P's. So first one, it is purple or violacious, and it is polygonal, then pruritic, plain, or that means the flat lesions, and there are certain papules. So now let's see the image of this lichen planus lesions. So here you can observe that the lesions, they are violacious, that means purple colored, and they have a lot of sides, that is polygonal, and they are almost flat topped, so that is plain papules, and they are pruritic. Okay, now this is another classical feature of lichen planus. This is, you can observe white crisscross streaks on this surface, so that is Wickham striae, and when you apply a thin layer of oil, you can see it so much clearly. So this is Wickham striae, that is a classical feature of lichen planus. So this disease, lichen planus, can have association with some liver disorders like hepatitis C virus, hepatitis B virus, and primary biliary cirrhosis. So these are again the lesions of lichen planus. You can see the violacious polygonal papules. They are plain topped and pruritic. So this is mostly seen in flexural areas. So that is actually a differentiating feature from psoriasis. In psoriasis, mostly it has an extensor distribution, but in case of lichen planus, you have a flexural predisposition. So this is Carbonas phenomenon in lichen planus. So Carbonas phenomenon, it is the appearance of new skin lesions of a pre-existing dermatosis in areas of cutaneous injury. So in this picture, it is the Carbonas phenomenon in lichen planus on a surgical incision site. Okay, so this lichen planus, it is usually self-limiting within 1 year or 2 years, and when it heals, it leaves a hyperpigmentation, just like this. Okay, so when you look at the triggering factors for this lichen planus, certain dental amalgam, especially the mercury in dental filling, it can trigger oral lichen planus. Apart from that, certain drugs can also trigger lichen planus, just like antihypertensives, antimicrobials, antimalarials, antidepressants, anticonvulsants, like that. Now when you look at the types of lichen planus, you can get some acute widespread lichen planus. So this is which we have already said, that is violacious papules and plaques. They are widespread. That will be very sudden and widespread. So that is the first type. Now the second one which you can get, it is about the nail lichen planus. So you have a lot of features in nails in lichen planus. This is one such, that is the pup tent sign. So here you can see there is a tending. It is actually the result of the nail bed involvement that has elevated the nail plate in a tent shape. Now this is another feature where you can see the most common finding in lichen planus is the thinning of nail plate. So once again, you know that in psoriasis it is actually thickening of nail. In case of the lichen planus, you can get thinning of nail plate, which is the most common finding. Apart from that, you can also get some longitudinal ridges, subungual hyperkeratosis. Now all the 20 nails can get involved, that is 20 nail dystrophy, tracheonychia. The other causes of tracheonychia, I hope just recalling, like psoriasis, alopecia areata and all. So this is another feature of nail in lichen planus. Here you can see a Terrygem. This is the most classical feature. So in lichen planus you are getting dorsal Terrygem. That means the proximal nail fold is fusing with the proximal portion of the nail bed. So all these are features of nails in lichen planus. Now the third type you can get is hypertrophic lichen planus. So usually on lower legs and all you can get some hypertrophic plaques. So this first picture is clearly showing that hypertrophic lesions on the lower legs. Now when you look at the next one, you can see the center, you can see certain crisscross white Wickham striae you can see on the side of this lesion. Now so we have said about what is happening in the skin, just like violacious papules. We have said about the features in nail. We have said about the hypertrophic lesions. Now you can also get in oral mucosa. So we have already said about this Wickham striae in the oral mucosa that you can get in oral lichen planus. So in this picture you can see the dental filling, which is, we have said that it can have mercury, the dental amalgam. It can the mercury in this amalgam can actually be a trigger for oral lichen planus. So you can also see the Wickham striae here. So usually the commonest form which you can see in this lichen planus in the oral mucosa, it is almost in a reticulate or lacy pattern. So apart from that, you can also get some ulcerative or erosive form of lesion which can have a pre-malignant potential. So in this picture it is so clear that this is a reticulate pattern or it is having a lacy pattern. Now this is actually the Wickham striae which is present in lower lip. What is to note in this picture, you can clearly observe the lesion is not reticulate but it is ulcerative. It is erosive form. So what is special about this erosive form of or ulcerative form of oral lichen planus? It is having a pre-malignant potential. Okay, so it can be the oral lichen planus, either it can be of the reticulate pattern or it can be this one, the ulcerative form, but this is very rare. Though it is rare, it is having a pre-malignant potential. And now I would like to recall that the most common pre-malignant lesion that you can get in the oral cavity, it is leukoplakia. Other than that, you have a lot of oral premalignant lesions like leukoplakia, erythroplakia, now which we have said oral lichen planus, submucous fibrosis, actinic cheilitis, like that. So this is all about the follicular lichen planus. So here you can see it can even affect the hair follicles. So here it can cause inflammation and scarring. So this is scarring alopecia. Okay. So this is the scarring, you can see it is patchy and irregular. So that is giving a footprint in snow appearance. Now, in the scarring alopecia, it is actually, you can see the perifollicular blue-gray macules are observed. So I hope you can observe in this picture perifollicular blue-gray macules. So another one is about the actinic lichen planus. So actinic refers to sun. So this is actually triggered by sun exposure. So it can be on the areas like forehead. You can get some violacious macules on forehead. Now in the other picture you can see again the Wickham striae. So Wickham striae, you can get the most common site where you can see is the buccal mucosa. In others, this kind of skin lesions also you can get this Wickham striae. Now this is lichen planus pigmentosis. So here you can see it is pigmented, that means very dark brown macules. So predominantly you can get in the sun exposed regions like face and neck. So the name is lichen planus pigmentosis because it is pigmented dark and brown. Okay, so now this is all about the different types. I hope you have clearly understood. We have said about the violacious papules that you can see on the skin, the sudden widespread violacious papules, and you can even get it in the, you have some nail findings. You can get something in the oral mucosa, oral lichen planus, and you can get in the hair follicles, follicular lichen planus, and some hypertrophic lesions can occur. And there is in the areas of sun exposure, the violacious papules in sun exposure regions, it is actinic lichen planus. Now when it is more pigmented, a dark brown macules, it is lichen planus pigmentosis. Now let us look at histopathology of this. So the earliest pathological change that can occur is about the basal epidermal cell destruction. So it is also called as vacuolization of the basal layer or liquefaction of the basal layer. So remember that that is the earliest pathological change that can occur. So the keratinocytes in this basal epidermal cells, the keratinocytes will be destroyed by the dermal CD8 lymphocytes. So what happens to these keratinocytes? They will undergo either necrosis or apoptosis. So these necrotic or apoptotic keratinocytes are called as colloid bodies. It has different names like colloid bodies, cuvette bodies, cytoid bodies. So that is what actually marked in this picture, the cuvette bodies. So these are the necrotic or apoptotic keratinocytes. That means the dead keratinocytes. How they have died? By the destruction by CD8 T lymphocytes. Okay. So they got destroyed and they are called as cuvette bodies colloid bodies or cytoid bodies. So this is an autoimmune basal layer destruction. So what happens after this? These keratinocytes, they fall down and they are seen in the dermis. So in this picture it is clearly observed. You can see the dermo-epidermal junction. So in the dermis you can see the cuvette bodies. So actually the keratinocytes, you should see it in the epidermis, but what happened? They were destroyed, they died, they fall down, now they are in the dermis. So the just like destroying these keratinocytes, due to this autoimmune basal layer destruction and the liquefaction of this basal layer, not only the keratinocytes can fall down and not only they are seen in the dermis, but also the basal melanocytes, they can also fall down into dermis. So the pigment will be seen on the upper epidermis. So that is called pigment incontinence. Okay. Now you can see from above, that is hyperkeratosis and hypergranulosis have occurred. So what is the reason why you can get the Wickham's striae? It is because of this hypergranulosis, because there is a wedge shaped granulosa layer. You can see it as a wedge shaped. Now specific about this reti ridges. Reti ridges will be pointed at the lower end and they will have a sawtooth appearance. Now in the dermo-epidermal junction you can see a Max Joseph spaces. Okay. And also a band of lymphocytes you can see at the dermo-epidermal junction. So once again recall, first of all hyperkeratosis, below you can see hypergranulosis, which is actually responsible for Wickham's striae, and you can see the sawtooth appearance of the reti ridges. Now you can see the band of lymphocytes at dermo-epidermal junction. So interface dermatitis means together this band of lymphocytes plus the basal cell destruction or vacuolization is called as interface dermatitis. Okay. So regarding the treatment, the first line treatment for a limited disease, if you can give topical steroid is enough. But if it is a widespread disease, you can give oral steroid. Now as a second line, you can prescribe acitretin or phototherapy. Okay, so that's all about lichen planus. Thank you.